Well, colleagues, we are behind the schedule, as I said before. So now we are happy to give the floor to Dr. Yevdoshenko, to Dr. Petrovsky, Alexander Petrovsky, the main challenges of real-world data and real-world evidence, the lead of surgical method of treatment, breast cancer, Blохина Institution. You're welcome. Good afternoon, distinguished colleagues. Can you hear me? Yes, positive. Great. So I will try to share my slides. Can you see my slides? Yes, positive. Make it full screen, please. Thank you very much, Alexei. Thank you very much for rescheduling the time of my presentation because I have some time constraints. I will have to be there. Thank you very much for the understanding of my situation. So if we talk about the differences between RCT and the RWD, well, it's discussed quite a lot today. So let me give you a very short, brief intro. So in the real life, we see the situation which is different from trials, because when the trial is ongoing, we have very similar patients that are randomized between the main and control group, and then we assess particular results. Although when we face the reality, we see that our patients are very different, and the way how they get into the main and control group is also very different. But as a result of that, interpretation of data is really very difficult. That leads to the fact that not all the results that can be directly extrapolated to the real life. And this extrapolation could be very different. For example, there was a study on the role of sorafenib in hepatocellular cancer, HCC. Well, HCC is a very complicated disease and very few effective ways to treat. One study is SHARP, then Pacific study, and all of them showed that sorafenib increases the life expectancy of patients in patients with the advanced HCC, and actually no other options to treat, and that is why it's in fact one of the golden standards of treatment. Although when we analyze the real data, for example, in 2016, there was a study based upon the analysis. It appeared to be that the survival was the same, those who get and did not get the treatment. Because in the SHARP and Asia Pacific studies, they included patients with ECOG 0 and 1. But in the real life, these patients who have prevalent HCC in the good status, minimal number of such patients. And we actually don't always see the positive effect. But on the other hand, there are other studies that completely coincide, and the results completely coincide with what is going on in the real life. This is, for example, famous breast cancer, and this is a Milia study that introduced trastuzumab betanzine as one of the main drugs for the treatment of metastatic HER2-positive breast cancer. So in that study, the median of progression-free survival was 9.5 months, but in the real life, our Spanish colleagues made the analysis of their own data, and for them, the same parameter of PFS was just 10 months. So the same data, and later on, it led to the increase of the overall survival, and the median was 34 months. So in some cases, the results, they mismatch. The real life results mismatch trial results. But there are interesting cases when the life appears to be much better than the trial. This is famous NSABP study shown here that made revolution in the breast surgery when they compared This is Bernard Fischer initiated that study at the end of 1970s. So they compared the results of treatment patients depending on the volume of surgery. So mastectomy was performed, then mastectomy with radiotherapy or the resection of breasts. And finally, it appeared to be that the results depend on the prevalence of the tumor, so presence or absence of lymph nodes, but not from the type of the surgical treatment. But when recently, back in 2016, we analyzed the Netherlands database, it appeared to be that those patients who had organ preserving surgery live much better versus those who had mastectomy. So this is real life, and this is real life which is showing with the same stages of the disease that the add-on of radiotherapy to organ sparing treatment probably provides additional positive effects, and it leads finally to the improvement of the overall survival. What happens in our country? So RCTs are almost not carried out. Yes, we participate in some international studies, but we don't have our real ones. In oncology, well, single studies. So it's easy to count them because very few. That's why, in fact, we have just the real data, but we have biggest advantage. We have very good cancer registry, population and cancer registry, where we include about 97% of all oncology patients. So this is the situation which is much better than in Germany or in France, in many other advanced countries. So this cancer registry exists for about more than 20 years, and actually there is a very good filling in. So yes, it's working, and annually we publish brochures about the oncology care, about the mortality, morbidity, etc. And due to this cancer registry, we know very well how many patients, what diseases, stage distribution, etc. In the regions of the Russian Federation. Yes, we know that, but unfortunately, from this cancer registry, we even cannot imagine how they are treated, how they're all treated, and what are the results, because actually there is no link to the outcome, because our cancer registry is not providing that. Specifically, Vitaly was speaking about the importance of the clinical guidelines, methodological approach, their components. So here we all remember that about 1.5 years ago, there were changes in the federal law where it was said that the medical care is provided based upon clinical guidelines, and the rest is secondary. Standards of the medical care, etc. They should be based upon those clinical guidelines. Clinical guidelines in oncology, yes, they are available. Oncologists were the first who established the clinical guidelines according to the requirements of the Ministry of Health. And then this is probably the fourth version, and you can see it on the website of the Ministry of Health. And based upon that, system of disease-related group was designed. When every completed case was calculated, then standardized module was made, and based upon that, they calculated the cost of this particular method of treatment and particular group that meets more or less similarly the same price. And from that, we got tariffs to provide medical care. Although when we started, when all this federal project was initiated and some money came in the system, so everybody started thinking, but how we are going to calculate what sort of drugs should be procured by this money? So budgets came, so where to spend? And although there was a cancer registry available, but in fact, we had no idea how many patients should be treated by this or that scheme. And at the very beginning, it was quite a mess, specific chaos. And many regions could not provide the procurement of the drug because they did not know how much and what drug they need. So they made the calculators to help the specialists in the identification of volumes. although all the calculators were based on the expert position. For example, we knew that we have this amount of patients with breast cancer of this stage, but what scheme of treatment for these patients? What should be done? What should be provided? Or how many patients on the primary patients? How many patients progress? How many of them get first, second, third line of treatment? So all that is completely expert assessment. So these calculators helped to calculate the money, the amount of money. So, but if we start calculating by this calculator, then no federal oncology program will never ever compensate these costs that were needed for the treatment of oncology patients. So, and this is just anti-tumor treatment, no concomitant treatment, no other methods. That is why definitely real life, the exact knowledge on how many patients exactly we have, on what stage, how they are treated, what option of treatment they get. So this is really acute need because we need to understand how much money we need for the treatment of this or that pathology. Also, to help the regions, we establish reference centers that should help us to assess radiological and morphological methods of studies. If in the region they cannot perform it adequately, for example, if this is a clinically complicated case. So there are about 9 of them, and they're functioning now, and 9 more will be functioning next year. From 2019, we have reference centers, but actually the day before yesterday, September 22, we received a letter from the Ministry of Health to provide the information on the planned volumes. So big attention. So it comes on the 22nd of September. Please answer until September 23 until 3 p.m. And I got it very late in the evening, you know. So from the early morning, magically, you have to assess how many patients would need these services of reference centers in the framework of the whole project, interacting, combating with oncology, and what data should be used to assess that unclear amounts. Let's forget the fact that the source of financing is also not clear at all. So in order to improve the general understanding of what is going on in the real life in oncology, there is idea of we have this idea about 2 years ago and started it implementing. This is so-called vertical integrated information medical system in oncology. So as the basis of everything is clinical guidelines and also data from federal classificator of medical studies, classificator of medical organization, and classificator of employees, HCPs. So putting all that together, we need to understand what is going on with each specific patient in each specific medical institution by each specific doctor who is dealing with the patient, and whether this doctor has skills, capabilities, and opportunities, in fact, instrumental options to provide this type of medical care, which is declared by the medical organization, which is essential from the point of clinical guidelines. So by now, we have first results of this work. So this system is not yet working. So this is system at the stage of design. So we completed phase 1 on just one localization, breast cancer, and we established pilot basic part in national medical centers, specifically Blahina Institution, and also on several other pilot entities. There are 5 of them. So we started the work on the introducing all the information from the primary source documents from all medical organizations that are providing care to patients with oncology diseases, breast cancer specifically, starting from the suspicion of the tumor up to all types of treatment and rehabilitation, palliative care, etc. So hopefully one day, as soon as this system, vertical integrated system of medical information starts working, so our real data we will be able to make not from the expert decision. With that, I would like to thank you for your attention. If you have any questions, you are welcome. We are collecting questions, and we present these questions to the speakers later on at the end of the conference. And now I'm happy to give the floor to the next speaker. We are behind our schedule, and many thanks for the understanding of this situation. And I'm happy to give the floor to Evgeny Yevdashenko with the presentation of main challenges of real-world data and real-world evidence and possible solutions. Position of the clinician, who is a vice president of medical associations of doctors and centers on multiple sclerosis, who is a lead of St. Petersburg City Multiple Sclerosis Center. The floor is yours. You're welcome.